For this lecture, we will cover hemolytic disease of the newborn in Chapter 12. Hemolytic disease of the newborn and fetus is also known as erythroblastosis fetalis. Now, what this is an actual a type of anemia within the infant or the fetus while it's still in the womb. So fetal or newborn red blood cells are destroyed by some sort of maternal IgG type of antibody. Now, maternal antibodies, they have to, in order to cause that destruction, they have to be able to cross the placenta and then sensitize the fetal red blood cells, and that will actually shorten that red blood cell survival life within the fetus. Now, once the infant is born, they will still have that exposure or have those antibodies present, and so that's why it can cause issues in utero as well as once the infant is born. Now, one of the ways of how this happens is that you actually have your fetal cells that will escape into the maternal circulation. So somehow, some way, those cells cross back over into mom and then stimulate mom. Now, there's a variety of reasons of why this can happen. Typically, it's going to be a result of some sort of fetal maternal hemorrhage. So some bleed between that barrier between mom and the baby. Now, this can happen during delivery or certain procedures like amniocentesis or abortion type of procedures, if there's any sort of umbilical cord sampling or anything like that during the pregnancy, if there's an ectopic pregnancy or a rupture of that ectopic pregnancy, or if there's any sort of abdominal trauma to the mom during the pregnancy, so accidents, falls, things like that. Now, the fetal red blood cell antigens that the mother does not have is what actually stimulates the mother to produce those antibodies. So you can kind of think of it like being exposed through a transfusion. Something happens that causes those red cells from the fetus to be exposed to mom, and then mom is stimulated to make that antibody production. Now, those antibodies will actually bind to those fetal antigens, and then that's where that red blood cell destruction starts taking place within that fetal liver and spleen. So before birth, indirect bilirubin is actually conjugated by the maternal liver. So any of those waste products are actually going to go back and be processed by mom. So as the red blood cell destruction continues, the fetal erythropoiesis increases. And so you have erythroblasts that are released, as well as the edema starts to happen in the peritoneal and pleural cavities, and then that can cause issues within the fetus themselves. Now, cardiac failure can also result in that infant. Now, after birth, some of the issues that take place is the newborn's not able to conjugate that bilirubin anymore. So that unconjugated bilirubin will actually bind to the albumin, and then that kind of seeps over into the tissue, which gives the baby that jaundice appearance where they have that yellowing or golden color of the skin. Now, permanent brain damage can actually happen as a result of the bilirubin that will actually bind to those tissues inside of that central nervous system, so it can actually cause damage to the brain itself. So just to kind of recap, there are 3 factors that have to happen in order for hemolytic disease of the fetal newborn to actually occur. So these factors include the red blood cell antibody must be an IgG antibody. Remember, the IgG antibodies are the ones that are able to cross the placenta, as well as the infant must possess an antigen that the mother lacks. So again, this kind of goes back to that philosophy where if a mom makes an antibody due to a transfusion or some sort of exposure, then when you transfuse the mom any kind of red cells, then it has to lack that particular antibody. And it doesn't necessarily have to be a mom, but any patient that has an antibody, they have to be infused with cells that lack those antigens. So the fact that the infant has those antigens is what has stimulated mom to make those antibodies. And in this situation, those antigens, or the fact that the infant has those particular antigens on their red cell that the mom does not have, means that that infant inherited that genotype from the father, and therefore they have the father's genotype as far as the having those antigens present. For example, if father has a kill antigen but mother does not. Now, the antigens must be well developed at birth in order for that antigen antibody reaction to actually take place to cause that continued destruction even after the infant is born and mom's no longer able to assist with that process of cleaning up that bilirubin. Now, there are a few things that can actually cause the hemolytic disease of the newborn. So those particular antigens that are going to stimulate that production, they can be the D antigen, it can be the ABO antigens, as well as any of the other particular alloantibody antigens that we have discussed. So like your KIL, your RH1s, your Duffy, your KID, things like that. So let's just kind of break each of these down. So RH, hemolytic disease of the fetal newborn. This is the most severe. So this is when you have an RH negative mother who is sensitized at some point, usually during their first pregnancy, because they had an RH positive infant. Now, typically the first child is not going to be affected because it's going to take mom a little bit of time to kind of be stimulated and build up those antibodies. And of course, not everyone is going to produce an antibody to being stimulated by an RH positive antigen, but the possibility is still there, and this is when this happens. Sometimes you can have situations where mom might have a miscarriage or some sort of trauma and have a miscarriage and not really ever know that she was pregnant, and then she was stimulated in that process. And so it may just be a situation where you may have a patient on occasion that has an anti-D, however, there's really no history of them ever having a reason to be stimulated. So there are some situations out there where that can happen. Now, subsequent pregnancies are going to be affected if mom does produce an anti-D. So it's usually not going to hurt that first baby, but all the babies after that, mom's going to have that rapid response once the body recognizes those D antigens, and so it's going to produce those anti-IgG antibodies a lot quicker, so it's going to harm those subsequent pregnancies if they are Rh positive. Now, if mom has a subsequent pregnancy that is Rh negative, obviously that baby is not going to be harmed by those anti-D antibodies that mom possesses. So with an Rh hemolytic disease of the fetal newborn situation, when you do the testing, you are going to get a positive DAT because those IgG antibodies have coated those babies' red cells that are Rh positive. And what you will see with these infants is that they will have jaundice and or anemia that can happen due to that red cell destruction. Exchange transfusion may be necessary depending on the severity of it, as well as one of the preventative actions that can be done is to give the mom Rh immunoglobulin to prevent that formation of that Rh hemolytic disease of the fetal newborn. Now, ABO, hemolytic disease of the fetal newborn, is the most common type. It happens in about 1 in 150 births, and this is when you have mom who is group O, but the baby is another type, A or B. Just to remind you, it's mom typically is not going to have an AB baby. So if you see an AB baby born to an O mother, there are some very rare situations where that can happen. We've talked about those in other lessons, but that's not going to be a common thing. So with this situation, the first pregnancy may be affected simply because you are dealing with those AB antigens. So productions of mild symptoms are possible due to the fact that you have A or B substances in the tissue that may neutralize antibodies, and the fetus or the infant's red blood cells may be poorly developed at this point, and the red blood cell binding sites may actually be reduced. Now, with this, you can see some jaundice in these infants, and so what you would use to treat them is just some phototherapy, just to kind of assist that infant until that liver has matured and can start kind of processing those byproducts on its own. So here, just to kind of compare, you have a nice chart that compares your ABO and your RH hemolytic disease of the fetus and newborn. So it just kind of compares if it's an ABO type versus an RH type. So it just kind of gives you an idea. As you can see that your RH is going to be a little bit more severe. You're going to have those IgG type of antibodies that's going to be causing that destruction. So just kind of list the comparison of the two. What you can see as far as the hematology type of results, if you're looking on the slide, where you can start to see some indications that you've got some anemia taking place. And then of course the bilirubin is going to be one of the things that is going to be monitored to just see if how severe that bilirubin goes up, if there needs to be any kind of intervention before it hits the point of being able to cause brain damage. I believe about 14, I may be wrong on that, is about the level that they kind of watch, and once it starts getting above that point, they start kind of intervening with other measures, just depending on how severe it goes, to prevent that bilirubin from actually going and targeting those brain cells and causing that brain damage. And of course, you do have other types of antibodies that can cause hemolytic disease. This would include your IgG type of antibodies, more specifically like your anti-C or your anti-big K. So this would be mom's particular antibodies that are going to cause those issues. Your little c and big K are your more common, but there are others like your kid, your Duffy. And a good way to kind of check this without being very invasive, of course, you can do some testing on the infant. But if you take your paternal cells, because remember your infant's going to inherit your genotype from the mother and the father. So if you check and see, okay, what does father possess as far as those antigens? Let me check it against mom's serum and see if there's any sort of agglutination. And what this can do is just kind of point to some of those low frequency antigens that the baby could have inherited from dad. So some of the things that are done to kind of get ahead and try to ensure that the infant is protected as much as possible through that gestational period. What we like to do is do prenatal testing on the mom to check for some of these things to see if anything can be prevented or monitored along the way. So prenatal testing will serve two purposes. It's going to identify if there is an Rh negative female who's a candidate for Rh immunoglobulin, and it also looks for women who have developed any sort of antibodies that are capable of causing that hemolytic disease of the fetus and the newborn. So testing that can be done is initial prenatal testing. So usually most women, once they find out that they're pregnant, somewhere around that about 8 to 12 week period, the physician will go ahead and do the prenatal testing, which is going to include a blood type as well as an antibody screen. And what you're looking for is to see if, number one, what is their blood type, because we're going to pay attention to that once the infant is born. If mom is type O, then we're going to worry about those ABO incompatibilities once the infant is born, and we'll talk about that a little bit more. And we're also going to determine if mom is Rh negative. So if she tests Rh negative, of course, typically most facilities have their policy that they're going to do week D testing just to kind of confirm that she doesn't have any of those week D possibilities. But if she is tested and determined Rh negative, then we'll follow up with the possibility of those RhoGAM shots, and we'll discuss that. That antibody screen, if it is positive, of course, you're going to work it up and identify what that antibody is, and depending on what it is, then antibody titers will be performed to establish a baseline so that it can be monitored throughout pregnancy. Now, at follow-up visits, if mom has been determined to be Rh negative or to have an antibody, then what you're going to do is kind of look and see if any new antibodies have been formed, to look at that specific antibody to see if it's done increased in strength in any form of fashion. So you do those antibody titers as well as the ones from the initial sample, as well as whatever you collect about 2 to 4 weeks in various intervals. If you're monitoring that, if you see that increase taking place, then you might have to intervene in some certain procedures for that infant. Now, at about 26 to 28 weeks of gestation, if the mom is Rh negative, then they're going to kind of repeat that antibody screen just to confirm that she has not developed any sort of anti-D. And then what she will do is actually get a prophylactic RhoGAM shot just to kind of cover that last trimester of that pregnancy, so that if anything happens, then it can be prevent, if there's any kind of like trauma or injury or anything, then it will prevent that formation of that anti-D in mom that's going to hurt that infant. Also, if for any reason with those antibodies need to continue to be monitored, then that's going to also be looked at as well. Okay, so that antibody titer, so the titer will actually help to determine whether certain procedures should be performed throughout that pregnancy. So that baseline titer is determined during that first trimester, and then it will be repeated in about 4 to 6 week intervals, just depending on the severity of it. So we'd actually take those samples and they would be frozen and maintained in order to do those titrations in sequence to see exactly if there's any sort of increase. So if their titer has any sort of rise by 2 dilutions compared to that baseline, then that's considered significant. If the titer rises 16 or 32, it's usually going to be critical if it's especially an anti-D or other Rh antibodies. So again, just to kind of remind you of what those titers do, those titers, when you're actually going through and doing those titers with of course this is mom's serum plasma that we are testing here, and you'll go through and make those dilutions. So it'll be a straight serum of plasma in tube 1, and then tube 2 will be diluted out half, and then you'll take that and dilute it a half again. So you keep doing that dilution with mom's plasma. And for the 2 samples, so that first baseline sample as well as that additional sample, and you would do that screen of that select cell to see how strong that antibody is and to see at which point it titers out, so that if you, over that 4 or 6 week period, whatever your policy is for your institute, if you see that increase taking place, then you know that mom is continuing to be stimulated, those antibody production's getting stronger, which means that infant is going to be exposed to more of those antibodies and is going to cause problems. Now, based off of this testing, there are several procedures that can be done to kind of monitor things. One of those will be an ultrasound. So they can actually use the color Doppler ultrasound to detect any sort of fetal anemia. And so what they're looking for is increased cardiac output and low blood viscosity in that infant. And so the severity of the anemia is determined by evaluating the peak systolic velocity in the middle of the cerebral artery. This is just an image of that ultrasound and what they're looking for. Now, I don't understand what all of this means, but it has something to do with these peaks that they are looking for when they do that ultrasound to monitor that infant and to check for that fetal anemia. Now, another thing that can be done to monitor that infant is the amniocentesis. So they will actually take that amniotic fluid and scan it in the spectrophotometer. And basically what's happening is they're looking for a particular change in that bilirubin level. And it's plotted on a special graph here. And depending on how it plots out will depend on what they determine as far as the severity of that hemolytic disease. This is not really something that you see a lot of. It may be something that you will run in your lab, but some facilities may not have it. It'll just depend on the facility that you're at as to whether or not you'll do this particular test. Now the amniocentesis itself, there are 3 alternatives that exist based on the results of the amniocentesis. So it can be determined that the pregnancy can continue to term, that there's not any kind of severe, reaction that they need to address. Or they could determine that intrauterine transfusion is performed. I'll discuss that, I think, on the a little bit later in the slides. Or they could decide that an early labor should be performed, and they would determine that based off the fetal lung maturity, looking at that LS ratio to determine if the fetus can survive outside of the womb. And so if it's that severe, then it may be better to go ahead and deliver that baby so that they can do those procedures outside of the womb. You can also do a chordocentesis on the infant. So using the ultrasound, they'll actually take that needle. So very similar to the amniocentesis where they go in and get that amniotic fluid. With the chordocentesis, they will actually go straight into the umbilical vein, and what they'll do is actually take some of that fetal blood sample and do some checks on it, like hemoglobin, hematocrit, bilirubin, as well as doing the genotype on that infant just to look for some of those particular antigens that are present. Mortality rate for this procedure is very low, so the chordocentesis can actually be used for intravascular transfusion if there is a case of severe hemolytic disease of the fetal newborn and they are not able to deliver that infant early, so they could actually do that transfusion while the baby is still in the womb. Now the fetal genotyping, so of course, they would have to do the chordocentesis and get that blood, and then the fetal DNA can actually be typed using the maternal plasma during the 2nd trimester. And so what this will do is actually predicting the fetal genotype could avoid any sort of amniocentesis or chordocentesis if the infant actually lacks that particular antigen. So it's just a way of just kind of checking to see what kind of antigens the infant has, and then kind of comparing that against the maternal plasma just to see if there's any kind of issues that's going to happen there. Now the postpartum testing, so once the infant is delivered, if there are certain situations that have been met as far as the mom's blood type or anything like that, then there's testing that will be performed once that infant is born. So this will include D testing, ABO testing, as well as DAT. So basically you're going to do a 4 type, the D as well as the DAT on the infant, and you're going to do this off of the cord blood. So all infants that are born to Rh negative mothers are going to be tested, including doing a weak D test. There are things that can cause false negatives. Your false negatives could be that those D antigen sites have actually been bound by an antibody. So because they're bound, they're not agglutinating with your reagent. What you would have to do in this situation, if you suspected that that's what's going on, you would actually perform an elution to pull off that anti-D and to test for it to see if it is present and had been attached to those red cells. False positive results can happen because the weak D test is performed on the red blood cells that have been coated with the antibodies. So once you reach that AHG phase, then it's going to be positive because that is basically essentially like you're doing a DAT. So first it's going to look negative, and then once you hit that weak D AHG phase, then you're going to get some positive reactions. But you're going to be doing a DAT anyway, as well as you would need to do that RH control. So remember when we started talking about that weak D testing, if your RH control is positive or your DAT is positive, then you know those cells have been coated. Your ABO testing, so again, this is just your 4 type. Since baby has not really produced those ABO antibodies at this point, then those antibodies that would be present are mom's, and that's why we don't do that reverse testing to start out with. Now, we do some testing if we need to determine if there's any sort of ABO incompatibility, but to start off with, we do not do reverse testing. Again, cord blood, when the infant is in the womb, has this little coating in that cord, so you know how that cord's kind of got that weird jelly-like look to it, or jelly-like feel. If you've ever seen a birth or seen that cord, that umbilical cord, you can see that it's kind of thick like a rope. So with inside that cord there is something called Warthin's jelly. So not Werther's, not like the jelly you put on your bread, but this particular jelly just kind of inside of that umbilical cord kind of helps cushion it from any sort of kinks and nicks, because you know that baby's in there kind of moving around, so it kind of helps to prevent it from clamping down on itself. But when they do that cord blood collection, they're actually kind of stripping that cord blood into a tube that they're going to send you to do that testing off of that cord blood once that infant is born. So with that whole process, when the infant's born and you clamp it off and you cut the cord, so before the physician actually delivers the placenta, they'll actually collect that cord blood from what's still kind of connected to mom, and then that's what will get sent to the lab for testing. But in that process of stripping that umbilical cord, that jelly-like substance will also come into that tube. So that's why we must wash that away, because that can cause some false positive or false negative results with that being in that sample. Your DAT testing, if it is positive, elution may be necessary, because that means that the mom's antibodies, if we don't know what it is yet, or you might have to do some additional testing with mom's antibodies. But basically what means has happened is something has coated those infant cells, so we need to be able to figure that out. So if you have to do an elution of any sort, if it's negative, you could be looking at some sort of antibody to a low frequency antigen. If you do that elution and it's positive, your baby's is like a type A or a B and mom was O, then we know those anti-A or B have coated that infant cells, and so perhaps that there's a negative antibody screen, but you have these anti-A and B antibodies that are present, and so we know that there's an ABO incompatibility that's present. Okay, so just to run through that testing again. So beforehand in that prenatal testing, we've determined mom's blood type. So if mom is type A or B, we don't have to really worry about anything. But if mom is type O, we know she makes anti-A, anti-B, and we know that that can potentially cause some ABO incompatibility in that infant at birth. If mom's antibody screen's positive, then we know we need to monitor that throughout the pregnancy and even after delivery, just in case any of those antibodies have attached to those baby cells and have caused any sort of a positive DAT. If mom's antibody screen is positive, of course, we've got to work it up, determine what it is. Once that baby is delivered, if mom is Rh negative, then what we're going to do is a fetal screen test. So we're going to screen to see if any of baby cells have crossed back over and are present and free floating in mom's sample, so that we can determine if mom's going to need RhoGAM and how much RhoGAM she will need. And then if that is positive, then you would do that Clarer-Bedke test to get that exact determination of how much that bleed was. Now, once the infant is born, if mom has met any of the criteria, and that criteria is actually, I'm going to write those in here for you. So if mom is Rh negative, if she is type O, or if she has a positive antibody screen, then that's going to warrant us to have to test that infant once they are born. So if mom is type O, we're looking for the possibility of ABO incompatibility in an infant that is type A or type B. If mom is Rh negative, then we're concerned if the baby is Rh positive and that mom could potentially make anti-D. So this is going to be a case where we're kind of going back and monitoring mom. We're trying to prevent mom from making any sort of antibody. So that's where we've kind of got to evaluate if mom needs to have a fetal screen done. So that's going to kind of come back up here to this testing if mom needs a fetal screen. And then if there was an antibody screen that was positive, if mom has an antibody, of course, we're going to look to see if any of that has kind of coated the baby's red cells, see if there's a need for an elution to see if those antibodies are causing any kind of problems. In that elution, as part of that ABO incompatibility testing, we're also going to be looking to see if that anti-A or anti-B has coated that those babies' red cells, depending on what type they are. So your ABO, RH, and your DAT results need to be interpreted with caution when you have a newborn, because you need to kind of know the history. If there was any sort of intrauterine transfusion that took place during that gestation period, then you can have some discrepant results that are taking place because, let's just say for an example, if the mom was Rh negative and baby's Rh positive and that anti-D was affecting that infant, then that transfusion would have took place with the Rh negative cells, so that can kind of cause some discrepant results. And of course, your DAT could be falsely positive or negative due to that transfusion that took place in utero, because you are testing infused cells as well as the infant cells. So just kind of keep that as a mental note that you've got to have that history. Now, there are steps that can be taken to kind of help prevent that hemolytic disease of the fetal newborn from ever taking place. One of those is to kind of help protect mom. If mom is Rh negative, then she would be able to get Rh immunoglobulin, or what we call, the brand name would be Rogam. And so that Rh immunoglobulin is given to mom through an injection that will help to prevent that formation of anti-D. So basically what you're doing with these injections is giving the mother essentially a fake anti-D. So you give her this fake anti-D that will come in and act to basically coat those red blood cells. So if that infant is Rh positive, it's basically going to go ahead and coat those red blood cells that have crossed back over into mom, so that if they're already coated, then it's not being flagged, the body's not seeing it. So basically kind of just mask it, puts a little shield around it, because it goes ahead and coats that those D antigens from those infant cells. So this will be your infant, and this would be your mom. So it just kind of protects, or just blocks off those binding sites, and then it prevents mom from making those antibodies. So that's essentially what that Rh immunoglobulin will do. So a dose is given at about 28 weeks. So this is going to be going into that third trimester, and that's just going to kind of prevent if there's any sort of exposure, because that baby's making more cells, those antigens are getting stronger. So if there's any kind of exposure where those red cells are going to cross back over into mom, it's more than likely going to happen during that last trimester, where mom is at more risk for, falls and things like that, or injury. So it's just going to kind of prevent if any of those cells do cross back over, if mom goes into early labor or anything like that. Also postpartum administration. So after that infant is born, the mom, if the infant is Rh positive, so if you do that cord blood testing and we determine that the infant is Rh positive, then what we'll do is actually give mom a dose of that RhoGAM. Of course, there is some testing that takes place. Like we said, you got that fetal screen. If that fetal screen is positive, then of course you're going to do that Clarer-Betke test to determine that dosage of that RhoGAM that needs to be administered. More than one dose of that RhoGAM may be needed if that fetal maternal hemorrhage is determined to be more than 30 mLs, because one shot will cover 30 mLs. So one 300 microgram shot will cover 30 mLs of a fetal bleed. So how do we determine if any of those infant red cells have crossed back over into mother and that there was a fetal maternal bleed that took place? Well, one of the first steps that we can do is actually to do a screening. So to do the screening, we do a test that's called the Rosette test. A lot of labs will just kind of refer to it as like a fetal screen, is actually maybe what they refer to it as. Where you're actually screening to see if any of those fetal cells have crossed back into mother's sample. So what you actually have to do is draw that sample after delivery. So it has to be a postpartum sample. They cannot be drawn during delivery or before that infant is delivered. Because what you're doing is allowing time, once the infant is delivered, the placenta is delivered, if there's any sort of bleed that takes place, you're allowing time for those cells to actually become present in mom. If the delivery hasn't taken place, we can't really tell for sure if a bleed took place during delivery. But what you'll do is you actually get a sample on the mom, usually the next day after delivery, and then from that point you'll do the fetal screen using your fetal screen kit, looking for those rosettes. And so the maternal red blood cells are incubated with a specialized anti-D reagent that comes in that kit. And then from there, you'll add some D positive indicator cells that are specific to that kit. And then what you're doing is looking under the microscope and you're trying to see if you see any of these clusters of rosettes. So what will actually happen is if the fetal cells are there, of course the fetal cells have their Rh positive, so we know that we're expecting that D antigen to be present on those. If they're there, then this anti-D that we put in there will actually coat them, and it's a specialized anti-D. So it's basically going to go in, it's going to coat these cells. And again, this is going to be the infant cells if they are present. And so once we put those anti-D indicator cells in, let's do this a little different. Now these indicator cells, they're actually red blood cells, so they're not a weird color. But so we'll put these indicator cells in, and what will happen is they'll start kind of forming these bonds around the edges or the outside edges of these infant cells. And you'll get this process of, it looks really more like a clump, but it's supposed to be said to look like a rosette, like a flower. Like you've got all of these little extensions of cells coming off, so you kind of get that little flower look to it. Now, if you see these little rosettes, if it's less than 1 per 3 low power fields, of course you got to read your procedure because the procedures are a little bit different. Some will say so many per 10, so many per 5. So it's really dependent on your kit, but you're looking for a certain quantity of those rosettes per a certain power field. If you only see 1 or 2 here or there, usually depending on what your kit states, then they'll just get that 1 dose. It's considered that bleed was a low bleed, so that's a less than a 30 ml bleed. However, if you see more than a certain percentage, so in this case more than 1 per 3 fields. So when I say per field, if you're looking at a whole entire field under the microscope, of course it's going to be more rounded, and you look at 3 fields and you see those clumps, then that's considered positive. So if you've looked in 3 fields, we'll just do 3 fields, and in those 3 fields, this is just going to indicate red cells. But in one of those 3 fields, you did see clumping of those cells whereas these, they're just, those cells are individual, but that one field you saw, one rosette, so that would be this dose. However, if in more than one rosette per 3 fields, so let's just say you see 3 fields, nothing in these, but you see rosette clumps in this one field, you see 2 of them, then that would indicate that you're going to need more than one. Now, if you determine that you need more than one shot because that's whatever your rosette screen test said, then you need to do a quantitative bleed. You need to determine how much bleed has taken place. So the rosette test itself, you'll make your suspension of your maternal red blood cells. So this is that sample that comes within that 72-hour period after delivery, usually the next day, because you have to get that shot administered to that mother before that 72-hour period. So you'd make that suspension, and then you'd put 1 drop of your chemically modified anti-D. So like I said, this is what comes with the kit. It is chemically modified to be able to attach to those indicator cells. So you cannot use your anti-D that's in your reagent rack. You have to use what's in the kit. So that is mixed with a drop of your maternal red cell suspension, and depending on what your kit instructions say, usually it's going to be incubated 37 degrees, so that warm incubator for about 15 minutes. And then you actually do a wash step. You're removing anything unbound, so removing any of this reagent that's unbound. Wash it 3 to 4 times with your saline. If you have a cell washer, of course you can use a cell washer. And then you're going to add 1 drop of those indicator cells. Again, this is what comes with the kit. It's not your check cells or anything like that. It's the cells that come in the kit. You're going to mix those indicator cells, a drop in, with this button that you have washed. You're going to mix it, and then you're going to do a centrifuge. Once you do the centrifuge, then you're going to resuspend that cell button. You're going to do a gentle mix. You don't want to mix too hard because you can actually start breaking up those clots. But this is going to have to be looked at under the microscope. If you have one that is strong enough that you can see the positive reaction in the tube, it is bad. If you put it on a glass slide, you can look at it under the microscope. Some institutes have a little holder that you can put the tube in. It's got like a little groove in it that you lay that tube on, and then inside of that, let's see if I can draw it out for you. So it's kind of got like this little groove that's down in here that you will lay your tube in here, and then there's a little open spot in the bottom of it, so this is all solid, and then it kind of just grooves down to where it will hold that tube. And you would lay your tube, let's change our color up here. You'd actually lay your tube inside of here. I'm not very good at drawing. And when you look through the microscope in this little open area that's here where your light's going to come through your microscope, and it shines through, and you can see inside of your tube, and then you're looking to see if you actually have any of those rosettes present. So depending on what your instructions say as far as how many fields you need to review, your procedure may say a certain number of fields. So you look at those fields, and then you're looking for that rosette. Again, this is kind of what the textbook image is. This is what it really looks like. It just looks like a clump. So you can see these clumping of these cells where it has formed those rosettes. And so obviously in this one, just looking at that one field, we've got greater than 3. So that means we need to quantitate it. Now, to quantitate it, you actually do the Klauer-Bethke test. And so with this test, it's based off of the fact that the fetal hemoglobin is resistant to acid. So it will actually retain the dye, whereas the adult hemoglobin is not resistant to the acid, so you get that ghost-like cells. Remember, when an infant is making its red cells, infants have a different hemoglobin makeup. This is what we learned in hematology. Their hemoglobin makeup is different than an adult hemoglobin, so it takes them a little while to get that adult hemoglobin. So what you're looking for when you do this test, this Klauer-Bethke test, now it's a staining procedure where you'll make a smear with that maternal blood, do the staining process, and then you're looking for the number of adult cells versus the number of fetal cells, and you're going to get a percentage of how much of a bleed you have present, how much of those fetal cells have bled back to mom. So again, just to kind of reiterate, those fetal cells are what is staining that darker color, whereas those adult cells are going to look ghost-like. So that fetal hemoglobin is actually what's retaining that dye right there. So you can see the comparison of those fetal cells versus these ghost-like cells here, or the mom cells. And so that's what we're looking for. So you're going to count these cells, you're going to count the number of mom cells in each field versus the number of infant cells until you reach a specified number. Let's go through this equation. So just depending on what your procedure says, they could say that you've got to count 5,000 cells, 2,000 cells, 1,000 cells. You're going to have to go by what your facility says. But what you're doing is determining the bleed that's taking place. So to get that, it's basically going to be the number of infant cells or fetal cells compared to the number of mom cells. So whatever your facility says, if it says you've got to count 2,000 of maternal cells, then out of all of those cells that you're counting, how many of those are the infant cells? So it's very similar to how you do the retic. You're going around counting all the cells, but out of those cells, how many of those are the actual retics? Same situation. You made that smear, you're counting cells, but how many of those cells are the actual infants or fetal cells? So that's where this number comes from. So this situation here, or this example, that they give you, out of 2,000 cells that they counted, 16 of those were actually fetal cells. So if you do that equation and divide it out, it's going to give you a number. So this is basically your percentage of your fetal bleeds. And then from there, you're going to multiply that by the maternal blood volume. Now, you're not going to always be given that maternal blood volume. So the average is about 5,000. So you would take that percentage, multiply it by 5,000, and then that's going to give you the amount of the bleed in mLs. So remember, one shot is going to cover a 30 ml bleed. So if you've done this calculation and you determine that it's more than 30, then we know that mom's going to need more than one shot of that RhoGAM. So the next step that you need to do is actually calculate the number of vials. So again, we know that 300 micrograms is going to cover a 30 ml bleed. Now, if you give extra, it's not a bad thing. It's just going to be extra to kind of help coat any of those red cells, because again, this is not an exact number here. But what you're going to do is actually take that bleed in mLs and you're going to divide it by that whole blood bleed, that 30 ml. So we know that 30 mLs is going to cover it, or that one shot's going to cover a 30 ml bleed. So we need to determine how many shots do we need to cover it. So we take that fetal bleed, divide it by 30, and that's going to give us 1.3. So we know that we need at least 1.3 shots to cover that. But what we're going to do is we're going to use our rounding rules. If it is greater than or equal to 5, then you're going to round up. If it is less than 5, you're going to round down. So this particular one, we would round down to 1. And then with every calculation, this is very important. I think a lot of people miss this step. Every calculation that you do, you always add 1. Always add an extra dose. That extra dose is going to cover anything that we may have missed. So then you will add 1. So figure out how many you will need to cover it, and then you add 1 for that extra. Now, if it is determined that that infant is going to have some severe complications. That may be decided if that infant can't be delivered early, that they need to do an intrauterine transfusion. And so what this is going to do is actually help correct for that anemia and prevent any sort of heart failure that could happen in that infant. Now, when you do these transfusions in utero, you need to give group O Rh negative red blood cells. They have to be collected within the past 7 days, so it's got to be fresh. Those red cells need to be irradiated because remember, we've got to prevent that graft versus host disease. They should be negative for CMV or leukoreduced, which will be considered CMV safe. And they also need to be negative for hemoglobin S. Now, once the infant is born, if that bilirubin level is increasing, then they may determine that they need to do some kind of phototherapy. And so usually phototherapy is going to be used in your milder cases of hemolytic disease of the fetal newborn, just to kind of help out that liver with processing that bilirubin. And so they use that fluorescent light, that blue light, that will help to break down that bilirubin because that light will actually convert it. That helps it to be excreted in the bile. So it's going to kind of help aid that liver where that liver is not mature enough yet to do that process. If patient is unresponsive to this therapy, so if the infant is doing this therapy and those levels still continue to go up, then an exchange transfusion may be necessary. Another alternative, so you may have been told, if you're familiar with, if you've had an infant or someone in your family may have had to come home with these little bilirubin lights, or the physician may have suggested if bilirubin's up just a little bit, you know, put the baby in the bassinet, open their clothes up and stick them in front of a really sunny window and let that sunlight kind of come in and help assist with that. Because as you learned in chemistry, bilirubin is destroyed by light. So if you're doing bilirubin samples, if you're a phlebotomist, you may be familiar with this, that you'll put those infant samples inside of like a darker collection container, or you'll wrap it in aluminum foil or something like that. You're doing something to prevent that exposure to the light until it can be processed in the lab. Now, an exchange transfusion may be necessary. So this is what's going to replace 1 to 2 whole blood volumes. So in this process, it's going to hopefully correct the anemia without expanding the blood volume, because remember we learned about some of those reactions where you can actually give too much and the cardiovascular system cannot keep up. What it will do is actually remove the newborn's red blood cells and actually replace them with an antigen negative cell for whatever that antibody is. It's going to reduce that bilirubin because you're not getting that breakdown. You're going to prevent any sort of damage or brain damage that's going to happen. And it's also going to help to reduce that maternal antibody that is circulating. So ABO and Rh type N should be determined on the infant first, but group O or ABO compatible Rh negative cells should be given. If you're suspecting that there's an antibody that's a cause, of course you're going to have you're going to check that maternal as well as possibly the infant, just going to depend on your facility's procedure for what particular antibody it is, and you're going to give antigen negative for that particular antibody that's present. And again, we've already kind of run through what those requirements are as far as fresh blood, CMV negative irradiated, hemoglobin S negative, and liking those antigens, as well as being compatible with the maternal serum or that elution off of that infant's cells.